from the pharmaceutical treatment for hypertension. Do, do not abruptly discontinue beta blocker. This is another point in administration. Okay, look for this point. Then we have behind fundamental understanding point. Do not abruptly or suddenly discontinue beta blockers or alpha 2 agonists. Alpha 2 agonists. Why? They must be slowly tapered, to avoid triggering rebound hypertension. See, triggering rebound hypertension. Why beta blocker can, if we suddenly stop, can lead to rebound hypertension? What do you think? Yeah, you are really around the point, but let's be more precise. Yeah, any idea? Yes, guys. Why, if I stop suddenly this beta blocker, may lead to rebound hypertension because I'm treating hypertension, right? If I stop suddenly, I can cause hypertension. Do you think why? Yeah. Think about beta blocker itself. Yeah, why? But why lead to tachycardia? Why lead to increased heart rate? How? How? Think. Now look about the drugs. You know, when I say here the beta blocker, right? You suddenly stop that treatment for hypertension, you will lead to rebound for hypertension. You think why? Okay. So why taking this medication can lead to rebound? Yeah, already around, but let's see to understand, to link directly. Yeah, any idea? Okay, you can Google it also. Fine. Because we are here to know the knowledge behind that, and then we can to link. Yeah. Think about beta blocker itself. Why when I stop this beta blocker, she may say that there is no available blocking for beta receptor, so that can rebound. You think that can rebound suddenly? Why? Yeah. Yeah. Yes. Affect beta receptor. What did that mean? Yeah. Okay. Very good. Okay, you'll be more closer. Yes, very good. The beta will be more sensitive. Fine, good. Very good. That's what I want for you to think this way. Pharmacology, if you think in this way, it will be easy for you, really intense to study and read it. If just for remembering, you will evaporate like, you will read it now, you will go for next topic, already gone the first topic. Yeah, any idea? Yes. Yeah. Okay. So any answer? Any try? No. Surrender already. Give it up. Okay. I think see. This is from fundamental pharmacology. Normally, when you use beta antagonist, drugs that block the receptor, right? So that deactivate or inactivate the receptor. The compensatory mechanism will increase secretion of the receptor. So beta receptor secretion will be more, right? You get fine. So that beta receptor, as you mentioned, beta receptor sensitivity, but in other way, when you use beta blocker, so that when suddenly stop using this beta blocker for long time, so expression of beta blocker will be more than the normal level, right? So when I stop beta blocker, I already the agonist, the endogenous is available, not epinephrine, right? So that will directly stimulate the beta receptor. Last time, if let's say we have 100 beta receptor, using beta blocker, maybe we have 1,000 beta receptor using beta blocker. If I stop suddenly beta blocker, there's no beta blocker as she mentioned here that no available blocking the beta receptor. So that will be rebound of blood pressure. Okay, you get the concept. So using antagonist for quite time, it will let to express the beta receptor more than the normal level. So that when they have suddenly stop the beta blocker, so that a beta receptor be available. So they will stimulate by endogenous agonist. So that will increase the blood pressure maybe more than the previous reports. Okay. Okay, how about alpha 2? Alpha 2 receptors, we have one common drug, clonidine, and this is central drugs. What do you think about alpha 2 agonists? Yes? Well? Okay, very good. If you attenuate or reduce the number of alpha 2 receptor, what the sequence is? Very good. No related about alpha 1. Think about alpha 2 receptor, alpha 2 agonist. No, here if I use agonist, opposite will decrease. Decrease the alpha 2 receptor. If then decrease the alpha 2 receptor, yes, increase alpha 1 action, but how? Yes, guys. Yes, from where? From where they can come this more than the normal release of epinephrine or epinephrine. Okay, see, look, alpha 2 receptor is a presynaptic receptor, right? Is not, you will not find in the tissue, you will do in the presynaptic. Is a negative control for release of neurotransmitters, isn't it? Especially for adrenergic neurons. If this receptor will be less than the normal, so that release of these adrenergic neurons will be more than normal. So that's the point where they say that it will activate the sympathetic receptors. You get the point or not? Repeat. Okay. See, alpha 2 receptors, normally the location for these alpha 2 receptors in the presynaptic. So the main role for these alpha 2 receptors is regulate release of neurotransmitters, especially in the adrenergic neurons. Fine? So now, if I use alpha 2 agonist, the compensatory mechanism will decrease expression of alpha 2. Right? Decrease this alpha 2, you will decrease the negative feedback. Once they decrease the negative feedback from release of neurotransmitters, that means more neurotransmitters can be released. Right? So that can rebound the hypertension. Clear? Okay, very good. Okay. You want to take 5-minute rest?
Yeah.
Okay, if you have any question, you can ask me. Specific now, previously based on the disease, right? On the classes of use. So now I come that we need to discuss in the class itself. Okay, diuretics. We have two main classes in diuretics. We call thiazide diuretics or furosemide or loop sealing diuretics. But normally in hypertension, in the chronic hypertension, for the first line treatment is the thiazide diuretics. Only furosemide can be used in the emergency. Okay, malignancy hypertension. Furosemide is the member of the loop ceiling diuretics. So thiazide, okay, what the important point I need to mention here, just get some knowledge about basic pharmacology. After I give you heavy applied, right? So that's here slowly that I need from you to know some fundamental pharmacology, how this diuretic that can reduce the blood pressure, the volume, based on the volume, based on reduce the sodium reabsorption, so that we can see based on the side of action, mechanism, and mode of action. At the same time, we need to know what the most adverse effect, which already explained to discuss in some point there, so that you can link, so that easy will get understand our point. So that normally the side of action is sodium chloride co-transporter and early distant renal tubule. This is the side of action of the kidney. So that my question is coming. Describe the side of action of thiazide. So you have to know about this. It's work in the sodium chloride co-transporter in distal renal tubule of the kidney. Mechanism of action, I believe when I say mechanism is action is about action, isn't it? So either inhibition, stimulation, blocking, how to say activation, right? So here, for thiazide will inhibit this co-transporter. So inhibition of sodium potassium co-transporter. So now once you inhibit these co-transporters, so that you will prevent reabsorption of sodium to the blood, to the body again from renal. So once inhibition of reabsorption of sodium, they will develop osmotic pressure. So develop osmotic pressure, that water remove from low to the high osmotic, so that can water go with the urine and urinate the water, how to say, the excess amount of water not be absorbed. Okay, this is the sequence. Thiazide inhibit the co-transporter. This inhibition of co-transporter will inhibit reabsorption of sodium, right? Inhibition reabsorption of sodium from kidney will lead to accumulating of water in the kidney, right? You will not reabsorb the water to the blood circulation again. So that will be excreted with the urine. This phenomena or this process will reduce the blood volume, right? And sodium as well. So that reduce the blood volume, that will reduce the blood pressure indirectly. Okay? We have two examples here, hydrochlorothiazide and chlorothiazide. This is two examples for thiazide drugs. Okay. Adverse effect. I don't have time to explain the pharmacokinetic will be so heavy, so for me, I try to focus on pharmacodynamic part, so that can correlate with the hypertension and treatment of hypertension. Okay, the adverse effects include metabolic alkalosis, electrolyte abnormality like hypokalemia, hyponatremia, and hypomagnesemia, and hypercalcemia. Okay, because the other diuretic can say opposite, but this is called abnormality in electrolyte when using this thiazide. Okay, but even though our body system to control the electrolyte in the blood is quite strict, what we need, maybe you need to check, you ask your patient every 6 months to check this electrolyte in the blood. Okay. The metabolic effect like hypercalcemia, hyperuricemia, that when I say this thiazide or diuretic is you can use with the cure with the patient with gout, it can cause hyperuricemia. But until now, we didn't say why can it is the hyperuricemia. Still, we didn't answer that question. Okay, and also can cause sulfonamide hypersensitivity. What does it mean when I say sulfonamide? hypersensitivity, these classes of drug, they have a sulfur group within the structure. So some patient may be sensitive to this compound. So we call sulfonamide hypersensitivity. So that maybe is not suitable for some patient. Okay, any question in diuretics? Clear? Okay, for beta blockers, same now. Beta blocker have long been used in the treatment of hypertension. Yeah, they are particularly useful. See, particularly useful in the hypertensive patient with effort angina, so that you will be very useful in the hypertensive patient with the cardiovascular problem. You can see with this like angina, tachyarrhythmias, or previous myocardial infarction. Okay, that this this beta blockers can be very useful in this patient, hypertensive patient with the heart problem, so that can minimize the risk of the angina and other illnesses of the heart. So this is the advantage of the beta blocker. Okay, look for the second point. See, look for the second. Beta blockers are absolutely contraindicated in the patient with uncontrolled asthma or asthmatic patient. Okay? Absolutely contraindicated. Look for the second, another sentence, and relatively, so that there is some time can be used, right? When I say relative, not absolute, right? Their level is less. Contraindicated in other form of obstructive airways disease, like bronchial asthma. When I say bronchial asthma is not controlled, that means absolutely contraindicated. But if bronchial asthma may use, but with care. Since when I say relative, okay. It is also absolutely contraindicated in the patient with severe cerebral vascular disease and heart block. They're useful if the heart have arrhythmia, angina, because this beta blocker can be one of the drug in treatment of angina or arrhythmia, so that they have positive impact. But here in the heart block, no. If they have a severe vascular, no, they will worsening the condition. So will be absolutely contraindicated. Clear? Okay. So that, okay, we have these three classes I bought for you: atenolol, propranolol, and metoprolol. Please read about pharmacokinetic and pharmacodynamic for this class, for this drugs. Because one of these propranolol, which is the most common drug, is non-selective. It has first pass effect, and this dose you need to adjust after 2 weeks to 1 month for your patient. So please read about pharmacokinetic. I couldn't get time to put, I think, so much of information. But just I keep putting within brackets pharmacokinetics specialist. In pharmacodynamics, you can focus about intrinsic activity for beta blocker. Intrinsic activity. Okay. Beta blocker adverse effect, as I said, dyslipidemia, increased triglyceride, and reduce this good lipid level in the blood. Also, especially for non-selective beta blocker. Okay, high density lipoprotein, especially for non-selective beta blocker. That's from the study. Okay, that explain our point that why beta blocker in hypertensive with diabetic patient, right? Mask hypoglycemic and may increase the incidence of a new onset of diabetes mellitus. Okay. Erectile dysfunction. So this is one of the adverse effects for beta blocker. So you can expect your patient will not adhere to the medication. Okay. High risk of stroke. So that's so it's preferred to vasodilator beta blocker over non-vasodilator blockers. Okay, now this is about the drug that can regulate on the cardiac output and systemic volume of the blood, right? This is the second class that was discussed in the beginning. Okay, or mention about it. Calcium channel blockers. Calcium channel blockers, how to say, are functionally heterogeneous class of the drug. If you want to look at what mean of heterogeneous, you can figure out the pharmacodynamic one. Is calcium channel for two classes. Okay, the example we have here dihydropyridine calcium channel blocker. The example is amlodipine and nifedipine. Non dihydropyridine calcium channel blockers, veripamil and diltiazem, these two classes of drugs. Okay, the site of action is calcium channel in the cardiovascular system. The mechanism of action is blocking or inhibition. Okay. So once you block the calcium channel, so that you prevent the calcium accumulated inside the cell. So when they reduce the intracellular calcium, that you will prevent vasoconstriction. So that this medication can be used in the treatment of hypertension, especially to control the vessels too. Okay. Calcium channel blockers, especially for dihydropyridine, is recommended the first line as hypertension mentioned before, right? Okay. One of the advantage for calcium channel blockers is that reduce the stroke in hypertensive patient. So if you have patient that risk and may cause stroke or have some any risk factor, so that calcium channel blocker can be drug of choice. Okay, renin-angiotensin system blockers and calcium channel blockers as a combination, they have a superior to the other combination in lowering cardiovascular event. So normally this combination may prefer if they have any other complication in cardiovascular. Why? Based on the studies, they show that they have better safety profile. The better safety profile, that means less adverse effect and complication. Okay, the other classes, renin-angiotensin system blockers, we have three subclass here, isn't it? We have ACE inhibitors, angiotensin receptor blockers, and renin receptor blockers. ACE inhibitors, one of the first line classes, and we have captopril and anapril, and we have this is common on drug used in the treatment of hypertension. ACE inhibitors are effective antihypertensive agent which can lower the cardiovascular risk and reduce the mortality and morbidity in hypertensive and those at high cardiovascular risk. So that they prefer to give to the patient with cardiovascular which go under cardiovascular risk. They are more effective in preventing coronary artery disease in the patient with hypertension. All this based on the studies. There is no biological study explain why this is preferred this condition based on the post marketing using this medication and data collection from patients. In diabetic patient, ACE inhibitor prevent the onset of microalbuminemia, because we know one of the problems for diabetic renal insufficiency that can reduce albumin, should be appear in the urine, right? So that will be indicated for the renal problem. So that using these ACE inhibitors, so that may have a protective effect in the kidney in the diabetic patient, but contraindicated in chronic kidney disease. Okay, so that okay, the side of action for this one, angiotensin converting enzyme, which is responsible for conversion from inactive angiotensin 1 to active angiotensin 2. So that can activate that angiotensin 2 receptor. Mechanism of action is clear. Clear? Any question? I already hypoglycemic now. Sorry, but I think the topic is very important. Please. Okay, one point very important for IC inhibitors. I said that previously, angiotensin receptor blocker can be used if IC inhibitor cannot tolerate. Right? Isn't it? One of these symptoms of intolerate, they can cause cough. Angiotensin converting enzyme inhibitors can cause dry cough. I cannot treat it with if I give anti-cough. You think why? Good, very good. I like it. Yes, you think why? Why this class of the drug? Well, no relation with the small muscle respiratory, but they can cause dry cough. Right? Is it? See, angiotensin converting enzyme is in the blood. So that can convert the inactive polypeptide angiotensin 1 to angiotensin 2, which they activate the receptor. But how they involve? Okay, if the blood circulation in the smooth muscle, how they can involve? Because the angiotensin 2 receptors is not available in the smooth muscle of the bronchi. No. Yeah, accumulation of bradykinin. You can check, you can Google it, no problem. Just block the concept. Now we are in the free time. Just look the concept, and then why bradykinin can cause dry cough. That's the point now. You cannot beat it. But just I'm telling you, okay, it's enough to me to know that the concept. Then later on you can get more knowledge about this point. But here we don't want to know the rule in terms of biological level, because you need to in terms of management, right? Because if you say cough, I can give anti-cough. Is it can work? That's the main point, right? So you get the point why this IC inhibitors can cause cough. Clear? The last. Have you Googled it? Have you checked it? The hypoglycemic. I think hypoglycemic here is more than here. Okay, guys. But please, just put a line. Then when you have time, just look for this point. I think okay. What the other point here? The patient with renovascular disease and renal impairment may cause deterioration in the renal function and may occur with IC inhibitors. So if they have causes of renal problems, they make a worsening. Especially, and I said that IC inhibitors can improve the kidney function in the diabetic, but in chronic kidney disease, they make it worse. Okay, if there is a hyperkalemia or resist rise of serum creatinine for more than 30% from baseline with 2 months, the dose of IC inhibitor should be either reduced or discontinued. That means they have some underlying problem in the kidney. Okay? This IC inhibitors may increase also is contraindicated in pregnancy from the point, so that can affect the fetus based on the previous studies. So that if they hypertensive patient taking this IC inhibitors and then later on become pregnant, you have to change this class of drug. Okay. Angiotensin receptor blockers. The main point here only this alternate for IC inhibitors if you cannot tolerate, they can cause a dry cough that cannot tolerate with the patient, so maybe you can change to angiotensin receptor blockers. And you can see only angiotensin receptor 1. Okay? But I have here one concern I would like to keep in your mind later on. Okay? Angiotensin receptors, we have two types of receptors, angiotensin 2 receptor 1 and 2. Okay? And this ratio, they say that is selective for 1. But selectivity also sometimes is relative. You cannot trust 100%, right? Okay, so what the importance of it? Angiotensin 2 receptor or two receptor, that's one, right? 2 is involved in cancer. Is involved in cancer. So that if they have this drug no selective, may assume that this patient may have later on as a problem. This is just keep in your mind, because angiotensin 2 receptor 2 is involved in the growth of cell and proliferation. Just keep in your mind. It's not addressed very well in the literature review, but keep in your mind that may face some cases or my drugs. We don't know, because drug, what we utilize drug they use in utilizing other patient, and we agree that a new patient is a new pharmacodynamic and pharmacokinetics. Just keep in your mind. Okay, I think this is the main point I need to explain. Arabs are effective in preventing progression of diabetic neuropathy and may reduce the incidence of major cardiac event in patients with heart problem. So this I have advantage also that can be recommended to use in diabetic and heart problem. Okay, this is renin blockers. We have screen and remicrene available in the market, only 2 drugs. This drug only they can handicap the renin from their action. Only at the binding at the catalytic side, so that prevent activation of angiotensin 1 to angiotensin 2, or conversion from angiotensin 1 to angiotensin 2, so that can inhibit the sequences of vasoconstriction of angiotensin 2. And this they have indication only recommend in treatment of hypertension with the renal failure, with the heart failure. And the mechanism I already mentioned here. One of the pharmacokinetic, I put 2 points here, is bodily absorbed. At the same time also the main elimination or excretion way is through the hepatic or the liver. So that means if patient have liver problem, would be you need to adjust the dose. If have a kidney problem, you will know no problem, because the most elimination way would be through the liver. Okay. Another 10 minutes. Okay. Fine. Okay, so just I will try to give you the most important point, and please go back, go through the slide. If you have any concern, please don't hesitate to discuss with me. Okay. Alpha blockers and combined alpha and beta blockers. For alpha 1 blockers, don't mixing between alpha 2 agonists. Alpha 1 will be both synaptic receptor. Okay? And the most adverse effect for alpha 1 is both hypertension. Okay? This class of the drug, they have one advantage. they prefer to give to the patient hypertensive with, how to say, benign prostatic hyperplasia, so that they can facilitate and reduce the symptoms. Okay, for combined alpha and beta, they, especially we have two drugs, they reserve for few chromocytoma condition with this excess amount of epinephrine or epinephrine release, so that they prefer to use for this one. Okay. For alpha blockers, and okay, this is one. Okay, continue. Okay, what I need to say. Is it okay? Lavitro is safe in pregnancy, no issue. Okay, the intravenous formulation is useful in hypertension in pregnancy. Okay, cardiolol has been shown to be effective in hypertension and also improve the mortality and morbidity in patients with heart failure, because they have some intrinsic activity. I told you, just you need to focus on it. Cardiolol. Now for central acting agent. We have, last time I know that we have two drugs. This is third drug already added. Methyl dopa, clonidine, and moxonidine. Methyl dopa is what is like a false neurotransmitters. That means can go in the synthesis of noradrenaline and adrenaline, but at the end they will get methyl noradrenaline, methyl norepinephrine will be false neurotransmitter, will not activate the receptor. Okay, so that, and this is drug for of choice in the pregnancy, especially hypertensive with the pregnancy. Clonidine, we already discussed about it, is it activate the alpha-2 receptors, and alpha-2 receptor is a presynaptic. When I say presynaptic, that this drug have a regulation, a role of regulation of release of neurotransmitters. When activate alpha-2 receptors, that means no more release of neurotransmitters. Okay, moxonidine is agonist activity of, this is a new information, we call amidazoline 2 receptors. I try to find the literature review, no much information, but they have some biological, not related to the clinical, but let's mention it can be used as a monotherapy in patients with mild to moderate hypertension or in combination with other antihypertensive. It may improve the metabolic profile of patients with impaired glucose tolerance or diabetic, so that advantage. But you cannot trust the companies. You have to experience most of the time. Because business in two things, drugs and drug medication, not drugs outside. Okay, medication companies, and also armies and these tools, big business around the world. So you cannot trust, you have to practice and you have to. Rebound hypertension or cessation of this drug is less likely compared to the clonidine. This is the advantage of moxonidine. How? Because they say that they have specific receptor. We call midazoline 2 receptor, not even the alpha-2 receptor. Okay. This is the advantage for oncology. Okay, continue. The common side effect for central acting include drowsiness, dry mouth, headache, dizziness, and mood change. But they said moxonidine is less likely to cause this side effect because it will not affect on adrenergic receptor on your transmitter. It will work on midazoline 2 receptor. Okay. But this effect can be tolerated if you use for a few weeks. This effect can be removed. Okay. Moxonidine has been shown to increase the mortality. This is the disadvantage for this drug in the patient with the heart failure, and therefore is contraindicated. Okay. Remember, Mixolidine is contraindicated in hypertensive patient with a heart problem or heart failure. Okay, for direct vasodilators, in the Malaysia we have two drugs, hydralazine and minoxidil. And I give you one example. This minoxidil also they have another uses topically. You can see who want to use grow the hair, use minoxidil. Because due to the vasodilation and this effect. Okay, but anyway, the main point this drug is not recommended to use unless if you have experience and that condition because due to the complication and side effect. Okay. Now, okay. Oh, very happy. Okay, good, 50. Fine. At least you have rest. I think I come to the most important slide here. So I have another two slides. Come on, the information for you. Any question in the previous one? Clear? Yeah, okay. This the new drugs already under development. We have 4 classes. Just for your knowledge later on, you can go look for it. If you want to discuss, you are more welcome. But this is a new class, the drug already under investigation for treatment of hypertension. That gives us impression that still hypertension in management is still not that to the reach to the ideal condition, right? Okay, last slide. Okay. For traditional medicine, normally in the guideline, because traditional medicine that means either practice or herbs, isn't it?
Yes.
For herbs, they not recommend because there is no strong evidence. Okay, but for practice, for relaxation regimen, can be recommended with taking medication. Okay, that's summary of this. Now, we already using the drug that can treatment of hypertension. Okay, using medication, but you think drug can cause hypertension? Yes. This is all the drug listed here that can cause hypertension. But I believe there is one issue is not clear. The threshold, how long, how much that can cause hypertension is not clear. I couldn't get any information for you. But keep in your mind, this medication and only the experience can tell you how the threshold of this medication can lead to hypertension. Okay? Okay, thank you so much. I think